Welcome to the STARS program, seniors taking active roles in society. And now, here's your host, ANITA FINLEY.
We have another fine doctor. We do a lot of physicians on this show as well as entertainers, and of course many physicians are entertainers. They have to be because of what they get through, what they have to do. But Dr. Zhang is a bariatric surgeon with Broward Health, Imperial Point. So welcome to our show, Dr. Zhang.
Thanks for having me.
I'm sure that it's a very difficult situation when someone comes in and I guess they're referred to from another doctor to a bariatric surgeon, because this is not something easy.
No, I mean, I think obviously obesity has some stigma. So most of the time when people are ready to come see me, they've had to kind of various commercial things such as Weight Watchers, Jenny Craig, and now they've kind of got to the point where they're considering surgery.
Help, right? Well, you brought up a very good point about people trying to do this themselves, but in bariatric surgery, you just don't do someone that wants to lose 10 pounds or 20 pounds, do you? What is actually your criteria?
So the National Health Institute criteria right now is that you have to have a certain BMI or body mass index. Currently, the guidelines that we follow are if your BMI is above 40, or if your BMI is above 35 and you have a obesity-associated comorbidity. So these are usually diabetes, high blood pressure, sleep apnea, high cholesterol. Those are the big ones.
So when you are seeing a patient, of course, who has been referred to you, and then are you the culprit in the sense of having to tell them what you're going to do? I mean, has this been explained to them before, or you're it?
Usually, what I like to do is usually when patients are interested in learning about bariatric surgery before they come see me, we usually have monthly seminars at Imperial Point. So they usually come. It's about a 1-hour seminar, and we give a talk about kind of what is obesity, why do we do the surgery, what are the surgical options, and kind of an overview of the process. This way, when they come see me, we can be a more targeted discussion, so we can be more specific for what each patient's needs are and kind of what they're thinking of in terms of the treatment.
We already have some people who are on Facebook watching you, and sometimes they ask us questions. If they do, then we'll respond to it. But, why don't you make believe this is a seminar? Why did you make believe that people who are listening would be attending your seminar? So why don't you say what bariatric surgery is, why, and all the things you just mentioned?
So the first reason we do bariatric surgery, first of all, is it's really metabolic and weight loss surgery. I think a lot of people think of it as weight loss surgery, but me as a bariatric surgeon, what I concentrate is on the metabolic part. And what I mean by that is the reason we do surgery is not necessarily for them to lose weight, it's for them to improve their comorbidities. So like the ones I talked about, diabetes, high blood pressure, high cholesterol, sleep apnea. The weight kind of comes with it, but the reason we do the surgery is to correct those things. Obviously, obesity is a big problem in this country. The latest statistics show that there's over 93 million Americans that are obese. That's about 40% of the country.
93 million.
And the healthcare cost of obesity is about $147 billion a year, and that's mostly related to the comorbidities, the diabetes, high blood pressure, and then the downside of that when people have cardiac issues with it. Actually, statistically now, obesity is actually the number 2 leading cause of death in the U.S. only after smoking. So it's a big problem, and
that's news. I'm sure our listeners are with their mouths open. I never heard that before, actually.
But so the goal of the surgery is to basically, like I said, reduce those risk factors. So I get patients that come to me with a goal in terms of what they want to lose weight-wise. But what I tell them is, the weight will come. But my goal, though, when I see you, is to, if you're a diabetic on insulin, my goal is to get you off of insulin. You can lose only 50 pounds, but if you're off of insulin, then I think we've kind of achieved our goals.
Okay, so those are a couple of things. But now, do you talk about what the surgery's like and what they're going to have to go through? And I'll just tell you something. I met someone that had, I think they lost 150 pounds, and then he had to consider other surgery to get rid of all that excess fat.
Right. There's several bariatric surgery options out there. I think the two most popular these days is the laparoscopic sleeve gastrectomy, which is probably the most popular one, and then there's the laparoscopic gastric bypass. So in the sleeve gastrectomy, we call it a sleeve gastrectomy is because basically we remove part of the stomach, and after the stomach is removed, the part of the stomach that's left looks like a sleeve, looks like somebody's sleeve, or like a banana.
Huh.
That surgery entitles removing about 80 to 90% of the stomach. Normally your stomach can hold about 1.5 liters to 2 liters of volume of food. So what we're doing, number one, is reducing how much food you can consume in one meal, but also by removing part of the stomach, we're changing some of the hormones that control appetite and metabolism.
Wow, that's quite a surgery. How long does a surgery like this take?
The surgery's gotten very, because we're doing it more and more often, it's actually a pretty, what I would say, relatively fast surgery in terms of that the surgery itself takes about an hour.
Really?
Yeah.
That's hard to believe. I mean,
Yeah.
we have, hip replacements and knee replacements take 2 to 3 hours.
Yeah. And I think that, with the technology kind of like, as we get better, I do a lot of these on the Da Vinci robot. So, your incisions are small, your pain is relatively minor, and most patients go home the next day. Actually, for a lot of patients, I tell them if you ever had your gallbladder removed or your appendix removed, the pain is very similar because the incisions are all the same size. About 1 centimeter, 1.5 centimeters is probably the biggest incision.
This is an amazing conversation. Thank you. I want to tell everybody that my guest is Dr. Zhang, and he is a bariatric surgeon with Broward Health, Imperial Point. So now, I guess the big thing is, what if they have had the surgery and they start eating again? Will their stomach expand? What will happen?
So the first thing I tell patients when they come to the seminar is that the surgery is just a tool, right? In terms of it gives you a tool to lose weight and improve your health long term. But what I mean by that is the surgery is only one part of the component. You have to follow the exercise. You have to follow the diet. What I mean by that also is in the first year after we do the operation, it becomes very hard for you to cheat. What I mean by that is, if you overeat, you will get nauseous and you will throw up. Okay, and when that happens, and there's some psychological conditioning in terms of kind of like someone who maybe goes out and has too much alcohol one day. The next time they decide to do it, there's a kind of a trigger of, I don't want to go through that feeling again. So usually for the first 1.5 to 2 years, the surgery is very effective because it doesn't let you do the wrong thing per se, because the body will make you feel bad if you do. But the human body is smart, so over time some of those triggers don't work as well as previously. But the goal is, why I call those first 2 years your golden years, because you have a tool, and with that tool what you're learning to do is adjust your lifestyle to eat properly, to eat the right amount, as well as doing exercise. And then over time, even if your body overcomes those triggers, you've kind of changed your lifestyle. That's the goal. So I tell patients, if you really want to be effective with it, you have to you have to participate with the surgery. It's not like you get your gallbladder removed and you can forget about it. You still have to kind of work on the other parts.
That's great. Well, I'm so glad. I don't think I've had a bariatric surgeon on speaking the way you have. I've had some on, but they do other things too. But this is your primary specialty, is it not?
Yeah, correct.
And why did you choose this as a specialty?
I really think it's...
I mean, you're so thin.
I really think it's because as a surgical specialty, a lot of times you operate on somebody and then you're done. I think this is the one specialty where you operate on a patient and then they're your patient for life. They come back to see you every year, make sure they're staying on track, make sure everything's working well. And the other thing is it makes a big difference in people's lives. One thing is the big thing is if someone is morbidly obese and meets qualifications for bariatric surgery, by having bariatric surgery, you're reducing their chance of having a health-related morbidity by 90%. So you're increasing their chance of avoiding some sort of health disaster by that much. So it's one of the few things where you can see a real impact.
And you talked about the Da Vinci robot system. So let's go back before that. I mean, you were working with your own hands, and I mean, I know you're working. You still have to use your hands, but you have a robot that's listening to what you're telling it.
So before we used to do these laparoscopic, the main thing about the Da Vinci robot is you're still doing laparoscopic surgery. So it gives the surgeons sort of more advantages, or makes the surgery easier. You can see better. You have more control of the instruments. There's more flexibility of the instruments. I guess when patients ask me, what's the kind of why the robot, the analogy I like to give them is basically, I think of laparoscopy as, let's say, a flip phone, okay? And so I would think of the Da Vinci kind of as an iPhone. It's still a phone. It still does what you need to do, but now you have kind of more options to, that makes it easier.
So do you also encourage your patients for psychological care so that they maybe do have the problem? A lot of people overeat because of, psychological problems.
Before, there's kind of a process before patients get to surgery, and one of the checklist things they have to do is see a psychological evaluation. Number one, it's helpful for kind of setting expectations and goals, but it also kind of eliminates any sort of psychological eating disorder, because that we wouldn't be able to correct with surgery.
Yeah, so it sounds like a wonderful thing that's happened. So what makes you decide one particular surgery compared to the other? You mentioned two.
So normally it's a patient decision. The way I talk to the patient is here are the options, okay? I think of it kind of like going to a car dealership and buying a car. You need
You're
a car,
good.
right? But there's different pluses and minuses to each procedure. So I kind of go through each of them, and then the patient decides. Because what I found is once you have the surgery, the easiest excuse for a patient not to follow through on the eating or the exercise is, the easiest excuse is, I didn't choose that surgery. I actually wanted the other surgery. So, by letting them have control of their decisions, they are more likely to follow through on the plan.
That's right. You're not the culprit, right? That was their idea. My guest is a very, very informed, very brilliant bariatric surgeon who's also very articulate, which is very good because people have all these questions, and that's what you're doing. They're sitting in their home or in their car listening, and they're saying, well, I didn't know that. So we're going to have you go to Dr. Zhang, who is a bariatric surgeon at Broward Health in Imperial Point. So I'm going to give you the way for people to get a hold of you would be to go to the website browardhealth.org, and I'm sure that they would find, they could look you up there. But let's continue with this. So do you have to involve other people with this when you have a patient? Do they bring their family with them? Do they you have a long discussion with their doctor? This isn't a solo decision, is it?
No. That's one of the key things I talk to the patient about, that this is kind of it's a group effort, and it involves your family, because number one, someone has to support you through the surgery, and number two, once you have surgery, the changes you get from surgery are going to affect your family members. Obviously, the big one is when you eat dinner, you're not going to be eating the same amount as them. You're also going to be eating a lot faster, meaning not a lot faster, but it's not going to take you as long to eat a meal. So those are things that they have to be, aware of, and they have to also encourage them to do the exercise part. It's always easier if you have an exercise companion to get you through the process, but it definitely requires a lot of support as well.
And the exercises, are they different from typical exercises? Because, once you've had your stomach cut or changed, does it affect certain kinds of exercises?
No. The good news is because we can do this surgery laparoscopic or robotically, Like I said, the biggest incision you have is about 1.5 centimeters. So once that heals, there's no regimen in what you can do. You know, you can be aggressive and do an Ironman. You can do CrossFit. You can do whatever you like. Just whatever. The key for me when I tell the patients is just do whatever you enjoy, so you keep doing it.
I'm going to ask you a weird question. What does the stomach look like inside? I mean, when you said that you're cutting it, I mean, what happens?
The stomach looks like I guess it looks like a balloon, sort of, you know. And what we do in the sleeve is we place a bougie or like a tube inside the stomach, and it sizes the stomach to the size we want. And then what we do is we staple or we remove the rest of the excess stomach. And in a bypass, we make the stomach, we make a smaller stomach, and then we connect the intestines to that smaller stomach, and it's called a bypass because the other part of the stomach in the beginning of the small intestines is no longer connected and never sees food. So.
And what happens to it inside? I mean, you actually take it out?
No. So one of the big differences between a bypass and a sleeve, and one of the things sometimes it ends up being patient preference, is in a sleeve you do remove the part of the stomach that we remove is sent to the pathologist and it's gone. In a bypass, that the part of the stomach we don't that doesn't see food still remains in the body. So technically, sometimes I get this question from patients: is, you know, a sleeve is not reversible because the part of the stomach we remove is gone, but a bypass is reversible if for some reason we needed to put things back to the way it is.
Why would you want to do that?
I've never had to do one. Never wanted to do that,
right.
But some patients like the idea to know that it's possible.
I don't want to be on this diet. I'd rather be fat, right? Oh, this is really a miraculous thing. Now, are there age limitations? If someone comes in and they're 80 years old, would you do it?
So I think initially when we set guidelines, there the initial guidelines that came out about 10 years ago, it was the age limit was like the age range was considered 15 to like 65. But
15, did you say?
Yeah, to 65. But I think now as bariatric surgery has become more prevalent, there really isn't a age restriction, because what the data suggests is if someone is going to live 5 years after surgery, then they benefit from the decrease in mortality. So, I've operated on patients, as old as 82 and as young as 13. So really, as lifespan increases now, like I said, the key is if someone is going to survive 5 years past the date of surgery, then they get the benefit of the surgery.
Okay, so of all the surgeries that one could have, on a scale of 1 to 10, how serious is this one?
All major surgeries involving the stomach is serious, but I think I can't really put a scale to it. But I will say, the chance of we can talk about complications. The chance of complications is about 1 or 2%.
Is that right?
Which is probably on par with other major surgeries. The chance of mortality is probably a little less than 1%. And the major cause that the major thing we worry about actually is blood clots. Most patients who are morbidly obese are at increased risk for blood clots. The surgery itself increases the risk of blood clots. So we're very aggressive in terms of getting the patient up and walking. Most of my patients, they have to ambulate the night of surgery. So once they wake up for anesthesia, they have to start walking.
Oh, my.
They get the blood thinners as usual, but what I found is mobility is the best key in preventing any sort of complication.
All right, that sounds really wonderful. I'm sure they said, I don't want to get out of bed, I just had surgery, but you're very confident. I can see why people would enjoy going and having this done if they have to have it with you. So this is do you work with other bariatric surgeons, or you the only one there at Broward Health Imperial Point?
I just recently started Broward Health Imperial Point, but we have plans to build what we call a comprehensive center of excellence. And there will be another surgeon joining me soon. But what I mean by a center of excellence is we're going to provide all the supportive care necessary for a successful bariatric program in Imperial Point. So this includes nutrition, psychology, support group.
That's excellent. That's really what people need. And I'd like to go back to what we were talking about. So how heavy has your how heavy have your patients been? What's the heaviest person? That's what I want you to know that you've ever operated.
So
on.
actually, most patients are probably in the 250 to 350
Really?
pound. But the heaviest patient, I've operated on patients as much as like 650.
Oh,
So
wait a minute, I'm fainting. Wait a minute. You're kidding. I mean, how is that even possible? How do they even fit on the operating table?
Well, that's part of, we have special operating room tables, special beds, and that's part of, building a center of excellence is you have to have all those accommodations for, morbidly obese patients.
So we started early in this conversation that someone who is probably maybe 75 pounds or 100 pounds, depending on what their other problems are. But you said that you really have operated on someone 650. I can't even fathom that. That must be terrible, in a sense, for you. But for them, they're so thrilled because, mentally, that must change their life.
Yeah, I mean, and that's part of the joys of being a bariatric surgeon, because there's few impacts you can have on people where their whole life changes. They come off their medications, they don't need their sleep apnea machines. I've had patients where his main reason for having surgery is because he went to Disney World with his kids, and his kids wanted to ride on a ride, and he was too heavy to get on. And that was kind of his motivation for having surgery, because that's what kind of finally hit him. Like, this is impacting my kids. And then, his first thing is 1 year anniversary, he went and got on the ride because he lost the appropriate weight.
Well, I've been on airplanes where people maybe have to sit next to me. They can hardly get into the seat. And I feel very embarrassed for them, but I haven't really, and I always think about the health aspects. As a gerontologist, I'm really interested in the elder population and what's going to make them live much longer. And this is something that I don't know if a lot of the elders even would have considered years ago. But now you make it sound so, it's not that it's just easy, it's just that there's so many interesting new, I would call them inventions, or just like you said, the Da Vinci, the Da Vinci robot, and someone like you that's been sealed in this, and this is what you do, and you've done so many of them. So this is a wonderful conversation. I'm really happy that you're here. I know that people are sitting there, and first they shouldn't be sitting there. Get up, right? Don't sit. The most important thing is that you want to go to someone who's very experienced, because this could be a dangerous operation if you don't go to someone who has great credentials, is a fabulous hospital, and has a lot of experience. Yeah. Have you had to? Has anyone come to you where they've had something done and it was not done well? A good portion of any bariatric practice is what we call. There is unfortunately a good portion of what we call revision surgery. Okay, and that sometimes it's because the stomach, something technical, or sometimes just something's not right with the anatomy. There is a lot of older patients I get for revisions because they've had procedures that done in the past that we don't necessarily do anymore, and what we have to do is we have to revise them to one of the more mostly like a bypass or sleeve, so to the anatomy that we're familiar with now. So here you did explain both of them very well. I mean, it would be a hard decision to make, and I don't know why, but the outcome is the same. It's just it's what you have to think about, right?
Yeah, the outcomes are very similar. You do lose a little more weight, and you do kind of gain a little increase in kind of in benefit in terms of decreasing your chance of diabetes. But with the bypass, but the trade-off is it's a little more surgery. So the natural history of the sleeve actually is when we began doing the sleeve about in the 2000s was we actually began doing sleeves on super obese patients that are like 650 pounds, some that we thought couldn't tolerate a bypass right off the bat. So the idea was to do a sleeve, get them to lose some weight, increase their blood pressure, increase their comorbidities, and then we can always go from a sleeve to a bypass. But what we found was a good percentage of those patients actually just got better with the sleeve itself, and that's kind of how the sleeve became a primary procedure.
So let's go back to the question that I think I mentioned before. So now you have someone 650 pounds. Let's not even do it that much. Let's tell someone that was 300 pounds and you've done this. What happens to the excess fat on the outside?
So one of the common questions I get from patients is they worry about the excess skin. Okay. What I tell patients, number one, is if we reach the point where the excess skin is your biggest problem, number one, we've already achieved our goal, because our goal was to lose the weight and get your comorbidities better. Usually when you have excess skin, you've hit that goal. As far as the excess skin, what I've found in most patients is if you're very vigorous with the exercise, the skin can kind of recoil a little bit, not be so excess and bothersome. And for a lot of patients, sometimes the areas aren't actually anywhere noticeable, so it doesn't bother them. But the final thing is, if it becomes a thing where it becomes bothersome, then most of them will go ahead and have some sort of plastic surgery to kind of remove the skin. But I do tell my patients you have to be patient, because I want you to be done with all your weight loss before you go to the plastic surgeon, because you don't want to remove some skin and then have more excess skin and have to have it done again.
And also because it is surgery and there is anesthesia, and people, you don't want to have too many surgeries. So I can see what you were referring to. This is your patient for life.
Yeah.
You're going to see them and you're going to be able to counsel them and say, yes, you should do it. No, why did you think about it, right?
And the other thing is, sometimes once patients have had bariatric surgery, other surgeons aren't necessarily comfortable performing the other routine surgeries. So, if they need their gallbladder removed, their colon or their appendix, they usually get referred back, because not everyone's comfortable in a patient that's had bariatric surgery.
Wow. Dr. Zhang, this is absolutely fabulous. I'm so glad you came. Everyone can go to Broward.org on the website and look for Dr. Zhang, who is the bariatric surgeon there at Broward Health Imperial Points. Thank you so much for sharing all your information.
Thanks for having me.